The next speaker is Dr. Özden Altundağ from Başkent University in Ankara. Her topic is recurrent ovarian epithelial cancer after PARP. What does the evidence say to us? Please.
Hello everyone. I'm a medical oncologist working at Başkent University, Ankara, Turkey. I'm delighted to being here, beautiful city Cairo, and this highly scientific symposium. Thank you very much for your for local and both MEMAGO scientific committee to invite me to talk about recurrent epithelial ovarian cancer after PARP. What does the evidence say? My job is easy, but difficult. It's both because there's few evidence we have so far. Several considerations for selections needs to choose for both first-line, second-line therapy or recurrent therapy. In the recurrent setting, beyond the other factors, timing to recurrence and the previous treatments are important, including PARP inhibitors. It needs to careful attention to select the right drugs. So we are now in the PARP era. What's next for PARP inhibitors in epithelial ovarian cancer? Indeed, although PARP inhibitors have led to considerable benefits, but patient selections remains a challenge. Not all patients benefit from this treatment, and response is not definitive. And hence the question of how to best treat patients who progress remains open, because data regarding PARP inhibitor resistance currently derived from retrospective data, preclinical or early phase trials, and require clinical validation. And there's some potential ways to overcome the overall benefits of PARP inhibitor resistance. Maybe we have to deeper understand the landscape of PARP inhibitor resistance mechanism, and maybe we can overcome the resistance. And we have to identify new strategies to enhance the scope of PARP inhibitors through combining PARP inhibitors with other drugs. So indeed, we have several mechanisms can lead to tumor switch from HRD to HR proficient and develop resistance. There are well-known resistance mechanisms I just summarized here. The most one is a restoration of homologous recombination. This is the most common resistant mechanism for BRCA and ROD51. Second one is the alteration of drug reflux pumps and tumor microenvironment impaired to drug delivery, leading to tumor resistance, and some signal transduction pathways may promote HR and evasion of apoptosis, and finally, replication fork stability allows to DNA repair and fork restart. If we know that mechanism, maybe we can overcome the resistance. Another problem is that due to cross-resistance between PARP inhibitor and platinum, key problem is that the platinum free interval is very important. Progression to first-line PARP inhibitor make a huge clinical challenge in daily practice, and best treatment algorithm after PARP inhibitor progression needs to be progressively validated. It is important to question that can we delay or prevent cross-resistance to platinum in patients receiving PARP inhibitor therapy. So it's a very difficult question to answer, but we have some important data available there. We have some clinical evidence. These are the prospective trials, but we have retrospective subgroup analysis of these group of trials. We have some data from recurrent treatment and few data from second line and first-line maintenance. Let's look at recurrence group. We know that the SOLO3 trial for olaparib versus chemotherapy in platinum-sensitive patients received 2 or more line chemotherapy, and then progressed randomized to olaparib, only BRCA mutant patients include this study versus non-platinum chemotherapy. In the first analysis, progression-free survival and overall response rates are favored with olaparib versus chemotherapy. However, if you look at the updated data, olaparib was a less benefit for overall survival over the chemotherapy. If you see the hazard ratio 1.33, olaparib for germline mutant advanced ovarian cancer who received 3 or more lines chemotherapy voluntarily withdrawn 2 years ago in the United States and all over the world, I think. And there is some explanation of this. They did a analysis, and they did a resistance clones with secondary BRCA mutations are more likely to be already present in patients with multiple prior lines of chemotherapy. These resistance clones then may be selected by olaparib therapy. Indeed, in the, 6 patients in olaparib arm had BRCA reversion mutation, 5 of 6 had 4 or more prior lines. So if we can use a non-platinum agent like paclitaxel or gemcitabine, maybe we can hit the BRCA reversion mutated clones, and then maybe we can do sensitivity to subsequent platinum or maybe PARP inhibitors. So, SOLO-3 trials show no responses in olaparib were seen in patients with reversing mutation at the baseline. You see 6 patients available here. But if you look at after the completion of the trial, in the olaparib arm, 22% of patients had BRCA reversion mutation detected in their ctDNA analysis, but only 3% in chemotherapy arm. So BRCA reversion mutation might lead to resistance to subsequent platinum-based therapy also. That's very important. ARIAD-4 is another single-agent trial. This trial designed almost same for SOLO-3, but they include the platinum resistance group. Chemotherapy is only weekly paclitaxel. They allow to crossover for weekly paclitaxel group to rucaparib after the progression. If we specifically look at the platinum resistance group, there is less patients did get a non-platinum chemotherapy. They did also translational study to identify a decrease in BRCA reversion mutation in 3 or 4 paclitaxel patients, pre and post-treatment plasma samples, and the fact that the paclitaxel may decrease pre-existing BRCA reversion clones may explain ARIAD-4 finding in platinum resistance cohorts. You see the progression-free survival was 7.3%, crossover the rucaparib arm in the paclitaxel patients compared to others. This is the hypothesis generating exploratory analysis, but that's the data. If we can overcome the resistance clones, BRCA reversion mutation with the non-platinum agents, maybe we can give olaparib or PARP inhibitors again, or maybe platinum again. How about the maintenance trials? This is the SOLO-3, SOLO-2. This is the olaparib second-line maintenance platinum-sensitive BRCA mutant patients. There's a post-hoc analysis we have that investigate the efficacy of different chemotherapy regimens following disease progression in patients who received olaparib versus placebo. And this is the hypothesis generating exploratory analysis that the PARP inhibitors therapy may reduce the efficacy of subsequent platinum-based chemotherapy. Indeed, there was a 7.3 months difference in time to second progression in favor to placebo over the olaparib. Look at the hazard ratio. The hazard ratio is 3. That's very important. So if they exclude the patients who received maintenance PARP inhibitor, it is still benefit with control group. PARP did not work. We know that the SOLO-2 patients, almost 40% patients did get PARP inhibitor if they progression. There is also another retrospective study from Italy. This is 66 patients who received olaparib for relapsed epithelial ovarian cancer and then further treatment evaluated. If we look at the sensitive, platinum sensitive group, there is 22% of overall response rate. This is the, if we think historically, we expected 50–60% of response rate, but there is only 22%. So data on post-progression treatment seems to suggest cross-resistance with chemotherapy, that we need to challenge it. Another multi-center real-world data, they look at the subsequent chemotherapy after progression to PARP inhibitors in a maintenance setting. They specifically look at the platinum-sensitive group, and this group analysis shows some overall response in the same. But if you look at the results, BRCA mutant patients presented higher rates of progression and worse survival outcome than BRCA wild-type patients that need to further consider the mechanism. So it's now well recognized that PARP inhibitors should be used in the first-line setting, at least in the BRCA mutant and HRD population. For example, if you look at the SOLO-1 trial, they include only BRCA mutant patients. You know, the cures were impressive. Everybody knows that these are the very good achievement for our patients for treating this group of patients. But if you look at the only SOLO-1 data, in 5 years, 75% patients received recurred in 5 years. That's very exciting. But if you look at the olaparib arm, 45% olaparib patients still recurred. So we have to understand the mechanism of their recurrence. There is a data from Paolo 1 presented this year at ANCO as a poster. I tried to understand because just different translation research they did. This is the post-op analysis for Paula 1, which is olaparib plus bevacizumab maintenance trial. They tried to find out the efficacy of subsequent chemotherapy in patients whose disease progressed on first-line olaparib plus bev, and to establish whether the timing of progression during or after completion of olaparib treatment and impact of efficacy of the subsequent treatment. If you look at the curve, if patient recurred under the olaparib was worse than the patient complete olaparib and the control group arm. And this analysis suggests that the timing of progression relative to PARP inhibitor independently predicts the efficacy of subsequent therapy with comparable efficacy between patients who progress after olaparib therapy and PARP inhibitor naive patients. And another attractive approach to overcome the resistance may be, I think this morning already discussed this issue, management of oligometastatic ovarian cancer recurrence during PARP inhibitor maintenance. There is then retrospective data coming from Italy. This is a retrospective single-arm trial. Recurrent ovarian cancer with oligometastatic progression under the PARP inhibitor maintenance. They did surgery or SRS, stereotactic body radiation for such recurrence, and PARP inhibitors still continued until the further progression. The primary objective was prolongation of the treatment-free interval after the PARP progression, after the local treatment. Indeed, 16 patients developed oligometastatic progression. If you look at the surgery and radiation patients, 6 or 10 months more patients did not progress after their local treatments. At the time of the publication, half of patients are still on treatment with PARP following the progression. So the hypothesis is proved that the patients, recurrent ovarian cancer, who have oligometastatic progression after PARP inhibitor maintenance may continue benefit from PARP inhibitor if combined with the local treatment. We have another data presented last year at ESMO. It's coming from France. 74 patients did get local therapy, radiation, or surgery for their oligometastatic sites, and they show almost a year progression without progression in relapsed ovarian cancer with continuation PARP inhibitor after local treatment for isolated progression. And this study confirmed it is feasible and it is potential benefit of this original strategy for oligometastatic progression under the PARP inhibitors. But more data are required to properly assess the safety for retreating patients with PARP inhibitor, especially when we considered myeloid neoplasms such as AML or MDS. There's an ongoing trial which is METO 45B, try to understand recurrent patients giving a PARP inhibitor maintenance and then progressed. They try to understand secondary cytoreductive surgery or at least resection of progressive lesions. They randomized to continue the olaparib beyond progression versus chemotherapy. Expected completion date is 2028. We have to wait this well-designed phase 2 trial results. So finally, we have prospective data test for PARP inhibitor rechallenge, as we are familiar with platinum rechallenge in ovarian cancer. This study designed one prior course of PARP inhibitor maintenance therapy, randomized to maintenance olaparib versus placebo, both BRCA mutant and non-BRCA cohort. And results show that the significant progression-free survival benefit in both arms. Interestingly, BRCA mutant, non-BRCA mutant cohort, almost same hazard ratios. But if you see the curves, it's very early progressive data available here. But if we look at in detail, in a year, 19% of olaparib patients still did not progress at the year, but if we look at the placebo, 0%. Number of mutant cohorts also same, 14% did not progress with olaparib, but the placebo was 7%. If you look at the HRD positive and HRD negative group, hazard ratios are almost same. So what's the evidence? We need more translational data on who would benefit from alternative of combination PARP inhibitor therapies. Due to poor outcomes and cumulative toxicity associated multiple sequence chemotherapy lines, enrollment in clinical trials strongly encouraged for platinum-resistant ovarian cancer. And we have particular attention should be paid to biomarker-driven treatments. So chemotherapy remains a cornerstone of recurrent ovarian cancer treatment. New and promising data are emerging in favor of chemotherapy-free alternatives. Equally effective, less toxic, easier to administer, and maybe delay to time to next chemotherapy. So we have mirvetuximab. This is the phase 2 Soraya trial. They allowed PARP inhibitor. This is the resistance group. 48% of patients did get PARP inhibitor previously. If you specifically look at the overall response rate subgroup analysis, this is show that the 38% patients did get response with mirvetuximab. If the patient didn't get the olaparib or PARP inhibitors, 25%. So we have a new options, and this is the phase 3 confirmative study. Patients randomized to mirvetuximab versus chemotherapy. Patients allowed to prior bevacizumab and PARP inhibitors. And in both arms, 55% did get PARP inhibitor previously. And look at the disease control rate, 80%. So indeed, there's an impressive result with 0.67 hazard ratio, 16 months versus 12 months for platinum-resistant ovarian cancer. How about PARP inhibitor previously treated patients? If you look at the all groups, in the subgroup analysis, PARP inhibitor patients get more benefit with mirvetuximab. You see the PARP inhibitor patients, the red arm is mirvetuximab. I believe mirvetuximab overcome efflux mechanism and increase the drug delivery into the tumor cells. And all these findings make mirvetuximab a leading agent in the platinum-resistant scenario, and its practice-changing, biomarker-driven standard of care. How about the other antibody-drug conjugates? There are several agents tried to research, but I just also mention Uplift trial. This is sodium 2B is a receptor. This 65% ovarian cancer expressed this receptor. It is very important for normal homeostasis. It's expressed lung, breast, ovarian cancer, but normal cells are limited expression. But there is a few or mild response with both ITT or receptor positive population. So as we talk about at the beginning, we know the mechanism. So several trials currently investigate safety and efficacy of combining PARP inhibitors with agents that target additional pathways outside of the DNA damage repair to overcome PARP inhibitor resistance. These are some promising molecular agents. I will talk about shortly 3 of them. First one is VE inhibitor, which is, I will talk about the mechanism, loss of p53 function, which controls G1S cell cycle checkpoint, and the cell cycle increases the dependence of the G2M checkpoint regulated, the checkpoint, and it is regulated by VE1 protein kinases, which is important ATR-ATM single transduction pathway. Adavosertib is small molecule tyrosine kinase inhibitor, show some activity in preclinical trials, and patients under the PARP inhibitors progressed received adavosertib or olaparib plus adavosertib. This is non-comparative trials, not randomized trials, and it is phase 2 trials. And the results show that overall survival, overall response rate is 29 months in combination, or even in adavosertib arm, 23% of patients did get results. Duration of response is fairly good. If you look at the BRCA mutant or MA wild type, the response rate is irrespective of BRCA status. In the concern of the toxicity, manageable those interactions, reductions. Okay, I will I'm going to finish soon. And another thing that we combined the anti-angiogenic with PARP inhibitors. They did already the genomic alterations of PARP progression. They found that reversion mutation is the most active mutation in the progression. It's cediranib, olaparib. Another mechanism is that we combined immunotherapy. I will talk about duo that we talk about today, and if you look at the results, HRD positive get more benefit, especially with HRD population. But if you look at the ITT population, durvalumab response is, there is a relative contribution of durvalumab. In the lack of olaparib arm, maintenance arm, we cannot make any comment. There is another current active trials that target the DNA repair, and so in conclusion, maybe it's the same in the beginning, identifying better predictive biomarkers of resistance to platinum and PARP inhibitors is unmet need. PARP inhibitor may comprise this response to subsequent platinum due to cross-resistance, and the potential benefit of PARP inhibitor rechallenge still needs further investigations. Despite the progressive knowledge, data regarding PARP inhibitor resistance currently derived from preclinical and early phase trials, and the question of how best to treat patients who progress remains open, and emerging novel treatments coupled with combination trials and biomarker exploration is offer encouraging results for potential strategies to improve response rate and progression-free survival. Thank you for your attention.